Good evening, everybody. Welcome to this poster podium presentation in Neuro Ophthalmology. And without much ado, we'll be starting with this. You have 4 minutes to complete this, and you'll be judged based upon how fast you deliver your talk and about the substance of the talk. So with this, we invite the first speaker, Dr. Nishi Satish, and she'll be presenting her talk on mitochondrial diseases of the eye, a plethora of findings. Over to you, Dr. Nishi.
Thank you so much, ma'am. A very good evening to everyone present here today. Like ma'am said, I'll be talking about the mitochondrial diseases of the eye. I have nothing to disclose. So mitochondrial DNA, we know it's circular double-stranded DNA, which is transmitted maternally. And here we've seen 10 patients who are diagnosed with mitochondrial disorders genetically, and we've tried to categorize them into their ocular and systemic findings. So the first group of presentations we saw were of optic atrophy, we saw retinitis pigmentosa, and external ophthalmoplegia and ptosis. So the first group, again, of patients with optic atrophy, we had these young teenage boys with bilateral painless progressive and sequential loss of vision. They had very strong maternal family history, and both of them had bilateral temporal pallor present, and on the visual evoked potential, we saw that there was a decreased amplitude as well as an increased latency. We called their younger asymptomatic brother over for examination as well. And although he was asymptomatic, we found optic disc changes in him as well, along with VEP and visual field analysis changes. We did a genetic panel testing for all of them and found that there was indeed a mutation in the G11778A. This was suggestive of Leber's. We sent these patients to neurology, and we found that although it appeared as isolated optic atrophy, they had peripheral neuropathy as well. We sent a patient to neurology. They sent a patient back with ataxia, tremors, a waddling gait, and she had difficulty in night vision since the last 2 months. When we examined her fundus, we found that there were some mild pigmentary disturbances present. We did an ERG for her and found that there were decreased scotopic and photopic responses. We combined all these findings together and thought, okay, this might be a patient of NARP. When we probed her further, we found that her younger maternal cousin also had similar features present. And when we did a genetic counseling analysis for them, we found that there was a defective ATP6 gene. Our next group of patients were of these ophthalmoplegia group, where this young girl with progressive ophthalmoplegia came to us. On fundus examination, we found that she did have pigmentary disturbances as well. When we sent her for a cardiac evaluation, we found that there was a first-degree heart block. Again, combining all these, we found that, okay, this might be a patient of Kearns-Sayre syndrome. And the next group of 4 or 5 patients that we had in our clinic were older gentlemen and older ladies who had chronic progressive external ophthalmoplegia. Some of them had cardiac conduction defects, some of them had sensory neural hearing loss. And the point here being that although the genotypic variations are so many, the phenotypic presentations of these cases are somewhat similar. They come with ophthalmoplegia, retinopathy, optic neuritis, and similar systemic presentations. One diagnostic tool which helped us a lot, especially in our ophthalmoplegia patients, was the muscle biopsy in the Gomori trichome stain, showing ragged red fibers. And new upcoming technology is coming up to recognize these fibers more easily. The treatment is common for all with an integrated approach, and the upcoming treatment in this is the gene therapy, especially for Leber's hereditary optic neuropathy. So patients with multi-system involvement, especially a younger age group with high energy utilizing organs, should prompt a suspicion for mitochondrial disorders. Family history is of utmost importance, and genetic counseling, especially regarding the maternal transmission, is very important in these patients. These are my references. Thank you.
So, with regard to Leber's, what percentage of patients do you think can have Leber's yet not show up on the primary mutations that we normally test?
So we test mainly for the 3 mutations on ND1, ND4, and ND6, and almost 70% of them do show up on that panel, sir.
Yeah, so I think earlier we thought was used to say about 90%
Yes,
have,
sir.
but now it's come down.
Yes,
There's
sir.
a lot of secondary mutations
Yes,
actually
sir.
come into play. And that's where if you do a good genetic counseling or you do a good pedigree, you can actually make out.
Yes, sir.
And it's not necessarily that Leber's would have a full penetrance in terms of.
Yes, sir. Exactly. Yes.
Yeah.
So how would you prognosticate based upon the genetic findings that you have? So you talked about genetic counseling. So for individual cases, the counseling would be different.
Yes, ma'am.
So what would be the likelihood for each of the cases that you described?
So in mitochondrial disorders, we have to note something about the penetrance of the disease, where we don't know how many percentage of these mitochondria which are affected will be transmitted to the offspring. This is very important in these patients. And regarding their familial history, especially the maternal background, we have to take all of those things into consideration while giving them that counseling.
Fair enough. All right. Thank you.
Thank you so much.
Dr. Nancy next.
Is Dr. Nancy Sharma?
Dr. Sharanya.
Can I start?
Yes, please.
Good evening, everyone. Today I'm going to speak about an interesting case. A pill provoked optic neuritis. Myself, Dr. Sharanya Krishnamurthy, hailing from Pondicherry. A 22-year-old female presented with the chief complaints of progressive painless diminution of vision in the right eye for the past 2 days following a single dose of oral progesterone, 200 milligrams, taken for the infertility treatment. On the first day of the examination, the vision in the right eye was 2/60 and she couldn't read any color vision. Her anterior segments were normal, whether in pupil the patient had grade 2 relative afferent pupillary defect, whereas the left eye is with a normal limit. On fundus examination, the right eye showed the media was clear, the disc, the margins are elevated and the disc is hyperemic except in 1 clock hour. The AV ratio was 2:3 and the bright foveal reflex was present, whereas left eye is with a normal limit. On fundus examination, we can see the margins are elevated in except 9 o'clock. So we took a OCT RNFL where there is a thickening of the neuroretinal rim. So we diagnosed the patient as a dry eye drug-induced optic neuritis, and we gave the patient on 3 doses of IV methylprednisolone, 1 gram, and then oral methylprednisolone 1 mg per kg body weight for 11 days, and calcium was given for the patient for 1 month. So first day, the patient vision was 2/60 with the elevated disc margins, whereas during the second dose, the vision improved to 660 with pinhole 612. Still, the grade 2 RAPD was present, and there was hyperemic disc with elevated disc margins except 4 clock hours. Whereas while giving the third dose, the vision was 618 with pinhole 69, and hyperemia of the disc was decreased. We compared this with the OCT RNFL of day 1, day 2, day 3. When we compare all the 3 days, the first day there was increased thickening in the in the neuroretinal rim. As the third dose, it came within the normal limit. At the last review, the patient vision was 618 with pinhole 66, and the pupil was normal reacting to light. The disc was normal in color with a cup disc ratio of CDR 0.2. And this was the day 1 of picture of fundus and the last final review. This is the OCT RNFL, whereas first day there was thickening of the neuroretinal rim, whereas it became into a normal limit in the final review. So my conclusion is the progesterone is a widely used hormone by the gynecologists. Though it is rare, it can be a cause threatening for optic neuritis. Hence, physicians should be aware of this unusual presentation. I think the probable mechanism is progesterone is has immunomodulatory effect, which can sometimes be pro-inflammatory rather than an anti-inflammatory. So the progesterone also has an effect on the endothelial cells of the vessels. So it increases the permeability, affecting the tight junctions of the endothelial cells. Apart from that, it can also lead a fluid leakage from the capillaries. It would have caused the disc edema and inflammation. Thank you.
What was the other disc looking like?
It was normal, sir, actually.
Let's go back.
Oh, I didn't put the other eye, but other eye was normal. Was normal, sir.
So what do you think would have happened if you decided not to give steroids at all? What's the outcome of these sort of optic neuritis? So we know that it's most likely fluid or inflammation, not demyelination in its true sense, right?
Yes, sir.
What do you think would have happened?
Okay, okay. It would have gone for an optic neuropathy, sir, maybe. That disc failure would have happened for the patient.
Yeah, so basically what happens is, this is, I mean, in these conditions, over time, it does tend to resolve on its own, but unlike the typical demyelinating rhinitis, which would resolve without much damage, these would end up with, certain amount of damage, which is either because of the compartment syndrome kind of a picture that will develop, because
Okay.
this is actually edema.
Okay.
This is not really, it's not so much neuritis as it is edema that develops after a slight amount of inflammation.
Inflammation, but there's a drop in vision for, which is just a,
This is there.
yes.
To say the damage is because of that.
Yes, sir.
Even the other eye would have actually, some of the disc is not here. If you looked at it probably carefully, you would get a subtle kind of margin change, which may not have gotten into that.
Maybe because we took the OCT RNFL also. For the, maybe I didn't put the, even in the OCT RNFL, there's no thickening at all. There's no inflammation. I couldn't see inflammation.
My one had.
Yes.
As Dr. Digvijay said, there is a mechanical element to it. But in addition to just OCT RNFL, you can also see the OCT macular GCC, because that also starts getting compromised. In addition to the RNFL value per se, looking at the cup volume would also add information, as you see. I just have one question, that why did you give oral steroids for 11 days? Like, how did we land up to 11 days as a number? It's like abruptly, I mean, how did you taper?
We have tapered like every 3 days once, because the vision got improved well in the third or fourth day.
That is not the correct protocol to decide on your own whether you are tapering in 3 days or 5 days. So the taper has to be like, proper
ONTT.
fashion.
Okay. Okay.
But this doesn't really fall into ONTT in terms of the kind
Yeah,
of
but still,
Yes.
3 days is like a system, yes.
In ONTT trial, they have given like 3 days
This is
of.
not optic neuritis per
Pers-
se,
uh,
as we would,
Yeah.
but even if it's drug-induced and you're treating on the lines of optic neuritis, like 3 days and 11 days, like it's a very random figure to, because just observing the improvement in the vision and abruptly stopping the drug when the patient lands up on 6/6 is not
No,
like
no.
the right way to do it.
No, that is the ONTT protocol, no, ma'am. 3 days of IV methylprednisolone followed by 11 days of.
Yeah, but you see, it does not. That's what I'm saying. It's not befitting the ONTT protocol. So now, I'm not offhand remembering the study, but for the drug-induced these things, they are trying to, till the time the drug is cleared off your system, they're trying to give the oral steroids a little slower taper than what we would do for an.
Even after the edema is resolved, even the vision is
Because
okay.
there is still subclinical edema, and that's why I said OCT macular GCC.
See,
would have sort of added on to more.
We took
information.
normal OCT macula, but I didn't do the
The
GCC.
MAC
Right,
GCC
see,
would.
keep the other eye pictures.
yeah, sure, sir. Thank you so much.
All right. Thank you.
We have Dr. Kapil here.
It's not mine. Just take this one.
Not this one. Not this one.
Kapil.
The other one can be ready on the other side, if that's working.
Okay. Good evening, one and all. Today I will be talking about live worm in retina with the diffuse unilateral subacute neuroretinitis. Approach to treat the live worm in retina with USN and the rationale for different techniques and their effectiveness. This is a case of a 66-year-old male diagnosed with elephantiasis of the left leg, presented with diminution of vision in the left eye since 4 days. The uncorrected visual acuity was 6/24, improving to 6/6 in the right eye, and 5/60, improving to 6/18 parts in the left eye. RAPD, that is, and color was present, and color vision was defective in the left eye. On the fundus photograph, disc edema with splinter hemorrhages with subretinal live motile worm seen with the wriggling movements in the macula was noted. You can see in photographs that the head end is moving, and OCT also depicts the subretinal worm. So we did focal laser to both the ends with a 532 nanometer argon laser with a power of 160 millivolts, and spot size of 200 millimeter, duration of 150 milliseconds. 5 spots were given. 3 days after laser, resolving disc edema with the dead worm was seen. Filaris is a common in India, and they exist as adult worms, elephantiasis, and embryos, microfilaria in the infected human host, transmitted by blood-sucking mosquitoes, Culex patogens. The endemic areas of lymphatic filariasis, that is Wucherer bancrofti, called as Malabar leg or Burgam Malai, are mainly along the sea coast and the banks of large rivers. DSN is a clinical syndrome caused by motile white, glistening, non-segmented nematome entering the subretinal space. The worm has been recorded in at least 2 different sizes, 400 to 1000 micrometers or 1500 to 2000 micrometers. It is characterized by vitritis, papillitis, and recurrent crops of white evanescent lesions, followed by several visual loss, optic atrophy, narrowing of the major retinal vessels, and diffuse retinal pigment epithelium degeneration. The pathogenesis of DSN seems to involve a local toxic effect on the retina caused by the worm byproducts, rapid loss of vision, and progressive optic atrophy, secondary to death of the ganglion cells, may be a remote reaction to the immune toxin. The visibility of a motile worm is the gold standard in making the diagnosis of DSN. Oral hand health mix and antimicrobials are likely to be ineffective because of the relatively impermeability of the blood-retinal barriers, though it is recommended for those patients who have severe vitritis, where the worm cannot be easily identified. The use of scatter laser photocoagulation in the vicinity of the multifocal active lesions when the worm is not visible was also used. The BRB function may be altered by severe vitritis and laser photocoagulation, and that might modulate the drug entry to the neuroretina. The Th1 and Th2 immune response may be impaired during infestation and return to normal levels between the recurrent bouts of infection. So the serological studies for detecting the worm, analysis of the stool for OVA, and the hematological evaluation for eosinophilia are of limited value, despite persistent survival in the relatively immune-privileged subretinal space. The aim of laser therapy is to achieve the death of the worm without inflicting the collateral damage to the macula. IV methylprednisolone 1 gram for 3 days, followed by oral steroids 60 milligram and tapering over 21 days, with albendazole 400 milligram immediately and diethylcarbamazepine 100 milligram TDS for 21 days, along with topical steroids was started to control the inflammation caused by the dead worm. Patient came after 3 days with resolving DSN, and dead worm was noted with improvement in the visual acuity. So we conclude that DSN is associated with severe visual loss. Early identification and prompt destruction of the infecting worm by laser photocoagulation, that is the treatment of choice, can preserve the good visual acuity. A combination of laser treatment, systemic steroids, and antihelmintics is more effective. References are there. Thank you.
So the laser treatment is always required, or you can just manage with the anti-steroids and anti-helmintics?
Yeah, first of all, live motile worm is very, if it is big, like as I told, only will be visible. Most of the times it is not visible. And if it is visible, gold standard is to do a laser unless and until it is located in the macula. If it is away from macula, we can always plan for a laser. And most of the times, as the live worm is not noted, so we go for alendemics and anti-inflammatory.
Unfortunately, in your case, you could
Yeah.
you go back to that picture also.
How can you be sure that it was filariasis?
A patient presented with elephantiasis of leg also.
Right. I'm sorry, I missed that.
एक slide एक बार लगाना। AV slide एक बार लगाना।
So,
Very interesting.
so this is the head end actually.
And these are usually,
So you can-
these are not solitary, right? I mean, there will be many in the body.
Main in the body. Yeah, patient already had elephantiasis of left leg.
These are just that one piece there is interesting.
You know, if you had put that picture, it would have added more power to your presentation. The
left,
elephantiasis,
left,
yeah,
left.
that. And the post-op one, I mean the post-laser.
This the disintegrated worm.
Thank you.
Thank you, ma'am. Thank you, sir.
So we now invite Dr. Manikandan Yoga Rubini to present post-operative vision loss following non-ocular surgery. Yes, please.
Good evening. I am here to talk about postoperative vision loss following non-ocular surgery. A 54-year-old male who presented with sudden painless vision loss in both eyes for 6 days duration. 10 days prior, he experienced chest pain. For that, subsequently, he underwent coronary angiogram that revealed 95% of coronary artery stenosis. Subsequently, he underwent coronary artery bypass grafting. On postoperative day 4, he developed blurring of vision in both eyes, for which he was started on intravenous steroids and antibiotics at the cardiac care hospital itself. He presented to us on 9th postoperative day. He is a known diabetic and hypertensive on treatment. His general examination and vitals were normal. His systemic examination and higher mental functions were normal. Ocular examination, his best corrective visual acuity in both eyes, half by 60. His color vision and central fields in both eyes were not accessible. Anterior segment examination showed 5 mm round dilated fixed pupil in both eyes. Posterior segment examination of right eye showed blurred disc margin with elevated pale disc and then pale area superior to fovea with absent foveal reflex. And the left eye showed blurred disc margin with elevated pale disc. The above clinical picture suggestive of bilateral non-arthritic anterior ischemic optic neuropathy with right cilio-retinal artery occlusion. We suggested oral corticosteroids for this patient, but the cardiothoracic surgeon prescribed antidiabetics, antihypertensives, and antiplatelets. Optical coherence tomography of right eye showed optic disc edema with a hyperreflective inner retinal layers in the macula, and the left eye showed optic disc edema with normal macula. On subsequent follow-up visits, his visual acuity was gradually improving, and the right eye showed 2 by 60 with resolving disc edema with pallor, and the left eye showed visual acuity of 6 by 60 with resolving disc edema and pallor. Coming to the discussion, optic nerve head supplied by short posterior ciliary arteries, and cilio-retinal artery is a branch of short posterior ciliary artery. Concomitant non-arthritic anterior ischemic optic neuropathy with cilio-retinal artery occlusion is rare. Even if it does occur, it is typically pathognomonic for giant cell arteritis. Our patient had painless vision loss with normal erythrocyte sedimentation rate and C-reactive protein, suggestive of giant cell arteritis unlikely. The mechanism behind this, the plaque released from common carotid artery, it went to the internal carotid artery, thereby blocking posterior ciliary artery. And the second one is marked optic disc swelling, which is inherent to non-arthritic anterior ischemic optic neuropathy, causing local compartmental effects around the disc, thereby compromising the circulation, and then concomitant cilio-retinal artery occlusion. To conclude this, postoperative vision loss in cardiac surgery is a rare complication. Even if it does occur, anterior ischemic optic neuropathy and retinal artery occlusions are occurred. Plaque in the carotid Doppler is more important than the degree of stenosis. Surgeons and anesthesiologists should be aware of the possibility of vision loss postoperatively. There is no proven treatment for anterior ischemic optic neuropathy and retinal artery occlusions. Stabilizing the hemodynamic derangement may be beneficial. Ophthalmologist consultation is necessary. There were few cases reported on perioperative optic neuropathy after cardiac surgeries, that is mostly of bilateral ischemic optic neuropathies. And some cases reported on after spine surgeries, there were retinal artery occlusions. There were one case reported on non-arthritic anterior ischemic optic neuropathy with a cilio-retinal artery occlusion with no causative agents. Thank you.
What is classically reported is the posterior ischemic optic neuropathies after cardiac surgery or very hypotensive episodes. How do you think that would differ from the anterior ischemic optic neuropathies? How would you be able to clinically differentiate the two? What would you look for? What did your patient have which was different? PION.
Yes.
So when there's a hypotensive episode, post-cardiac surgeries.
He's a diabetic, sir. The anterior ischemic is most common causes diabetic for non-arthritic anterior ischemic optic neuropathy.
So in PION, you would not get any disc edema.
Disc edema, yes.
It's only in anterior that you will see the disc edema. But a lot of these cases will actually have PION rather than
AION.
NAION. That's there. But here it was NAION, then you are looking for other risk factors or causes. Same, because the surgery itself is a stress
Yes.
for the person. So that itself becomes a very big risk factor. Somebody who's even relatively well controlled, I've seen maybe more than one case, in fact, maybe 2 or 3 now, that would end up with NAION picture. So yeah, that's one of the things.
What I really liked was that you have explained the mechanism by which the pathology would have occurred. So that was really nice. By any chance, did you have access to the pre-op carotid Doppler, or the post-op in
Yes, sir.
cardiology?
Yes, ma'am. Carotid
concept?
Doppler, it was showing the left common carotid bulb, plug in the left common carotid bulb.
All right. Thank you. Well presented.
Thank you.
So,
Sonali Gupta, yes. Dr. Sonali Gupta.
Yeah, good afternoon. I'll be presenting my paper on hypertensive retinopathy as an ophthalmic clinical biomarker of stroke in Indian subjects. So stroke is the second leading cause of death and a major cause of disability worldwide. Incidence of stroke rises as the population ages, and it has been observed that in low and middle income countries, more and more younger people are affected by stroke. So we aim to study any ophthalmic signs which could easily be observed in the blood vessels of the eye and could be extrapolated to those in the brain and could form a basis of a clinical biomarker for stroke. So we aim to determine a relevant pre-stroke ophthalmic biomarker, the presence of which could be used to predict high risk of stroke event in these subjects in the future. It was a prospective observational hospital-based study. 100 consecutive post-stroke subjects who were stroke survivors were evaluated in 2 tertiary care academic teaching institutions in northern India. A comprehensive anterior and posterior segment evaluation was performed along with any significance of any structural or functional visual parameter which we might find relevant for the occurrence of stroke. Pattern reversal VEP was performed in 83 subjects, and they also answered a translated version of the visual impairment screening assessment questionnaire. So we observed that the average age of subjects in our cohort was 50 plus minus 11 years. Out of these, 83 subjects had ischemic stroke, while 17 had hemorrhagic stroke. The most common systemic comorbidity was essential hypertension in 53 cases, diabetes in 7, combination of hypertension and diabetes in 30, with other rarer causes encompassing the rest. Thus, systemic hypertension in isolation or combination with diabetes was prevalent in 83% of our subjects and was the most common comorbidity associated with stroke. On examination of the fundus of these patients, we found that 34% of these 83 subjects had hypertensive retinopathy. This is one illustrative case whom we observed after surviving the thalamic stroke. He had an up-gaze palsy. On looking at his fundus, the right eye had hypertensive retinopathy changes, grade 2, while the left eye had hemiretinal vein occlusion, which is again a consequence of the raised blood pressure in the patient. He also, due to the stroke, there was an acquired blue-yellow color vision defect and a right-sided hemianopia as seen on the Estemans visual charting. So since in our cohort the average age was 50 years, which is less than the average age of presentation in the Caucasian counterparts, hence evaluation of clinical biomarkers becomes relevant because the patient might not have any other systemic features till then which can warn him of a future risk of stroke. So since it is easy to look into the eye, it is possible to evaluate the vascular changes of the retina, and the similar changes could be extrapolated to other parts of the body including the brain because the ophthalmic and neural event in this milieu is similar. So to conclude, hypertensive retinopathy in isolation does not cause a significant decrease in the central visual acuity in the absence of other associated anterior and posterior segment anomalies. Thus, it is a silent killer of sight. Appropriate evaluation for early hypertensive retinopathy is a relevant ophthalmic biomarker for subsequent stroke in the relatively high risk and younger Indian population. The easily performed ophthalmic procedure of ophthalmoscopy can be used to screen a younger, susceptible and vulnerable Indian population for hypertensive retinopathy, thus obviating many primary as well as recurrent stroke event in them and reducing the morbidity associated. Thank you.
Thank you. That was interesting. We know, I don't know if I'm getting my numbers right, but on an average, if you look at all stroke patients across the board, about 70 to 80%, maybe even 85% would be hypertensive.
Right.
All right. And what is generally the prevalence of hypertensive retinopathy in hypertensive?
So we found 35% of those patients who had hypertension in our cohort had hypertensive retinopathy, and since the screening program for diabetic retinopathy is well advertised and the physician is aware about the need to refer. But in terms of hypertension, the eye examination is really not taken to be done every yearly, or there is no set guidelines for that. So we wanted to highlight that if we look at the changes for hypertensive retinopathy, so it can also indicate that probably the blood pressure needs a better control, since the changes can lead to stroke in future.
Right. So, but what would be interesting to note is that so let's say 1 in 3 hypertensives has got hypertensive retinopathy,
Right.
and let's say 3 out of 4 stroke patients has got hypertension. So what is the overlap in that Venn diagram? So what percentage of people with hypertensive retinopathy would go into a stroke as against those who are not having
So in
hypertension?
our cohort, 24% of patients with stroke had hypertensive retinopathy.
So basically what it essentially meaning is that
1 in 4.
yeah, 1 in 4. So you would have to look at 4 hypertensives and one who was having a retinopathy to prevent a stroke. So that's a very good number to look for treatment.
Also, it would be important to see the grade of hypertensive retinopathy and how many of them had mixed retinopathies, because you said that there was
They were
a subset.
overlapping.
Yes.
Yes.
So, were the patients with mixed retinopathy more likely to develop stroke? And what was the grade? So, an ANOVA kind of test would have been run on these patients for regarding their age and the multiple comorbidities and gender, and that would have sort of
Maybe we are continuing this study for a
that
larger
would have
sample
added more
size.
information to
Yes,
it.
then probably this analysis would throw up some interesting results.
All the best.
Thank you so
Okay,
much.
thank you.
We have Dr. Ananya.
Homocysteine, yes, yes, yes. I thought so. Yes.
So I did read through those causes, but the ones which mentioned less frequent causes, only one patient had hyperhomocysteine. All of them were tested for it. Yes, we did that out.
Agreed.
Good evening, everyone. I'll be presenting a case report of non-arteritic ischemic optic neuropathy after an acute attack of primary angle closure glaucoma. So a 63-year-old male patient presented to our OPD with chief complaints of blurring of vision, redness, and pain in his right eye. 4 to 5 days back, he had presented elsewhere and was diagnosed as a case of acute attack of primary angle closure and was treated with IV mannitol, topical pilocarpine, oral acetazolamide, and he was started on topical brimonidine timolol combination. When he presented to R, and the intraocular pressure recorded then in the right eye was 44 millimeters of mercury, in the left eye it was 34, and in systemic history, importantly, he is a hypertensive patient for the last 15 years, being treated on oral antihypertensive agents. When he presented to our OPD, the visual acuity in the right eye was 660, and in the left eye, he was having 6/6 vision. The right eye pupil was pharmacologically constricted since he was still taking topical pilocarpine. The intraocular pressure was maintained at 16 in the right eye, left eye was 18. On gonioscopy, the right eye 360-degree angle closure, and the left eye there was 270 degrees of angle closure. So he underwent both eye YAG-assisted peripheral iridotomy and was asked to follow up after 1 week, and the topical brimonidine timolol combination was continued in both the eyes. After 1 week of follow-up, the patient complained of further blurring of vision, and he was complaining that he could not see objects on the floor. So his visual acuity in the right eye had reduced to 1/60, and he had an inferior visual field defect seen on confrontation test. Color vision, only the test plate could be seen in the right eye. Right eye also showed a relative afferent pupillary defect. The intraocular pressure was maintained at 18. On dilated fundus examination in the right eye, there was optic disc blurring that was seen, and of the temporal and the superior disc margins, and a small splinter hemorrhage could also be seen. Left eye, he had a relatively small disc with a vertical cup disc ratio of approximately 0.2. He underwent a fundus fluorescent angiography, and in the right eye, it was seen that there was a filling defect superiorly and temporally in the early arterial phases. So on basis of all of this, we made a diagnosis of non-arteritic ischemic optic neuropathy, and he was started on oral steroids with tapering of the dose. And after 6 weeks, the visual acuity in the right eye improved to 2/60 with maintenance of the intraocular pressure. The optic disc showed a complete resolution of the edema with an eminent pallor. So this is a comparison between his first visit and after 6 weeks. To discuss, NAION is presumed to be due to a result of hyperperfusion within the optic nerve head. So if there's a sudden rise in the intraocular pressure, that can cause a reduction in the perfusion pressure of the optic nerve head, leading to compression of the vessels, leading to NAION-like picture. The blood supply of the optic disc and the peripapillary choroid have been shown to be the most susceptible to be obliterated by the elevated IOP. And the blood flow to the optic disc is determined by mainly the resistance to flow and the ratio of the perfusion pressure. Resistance to flow can be affected by, is affected by the vascular autoregulatory mechanisms, which can be affected by systemic diseases like hypertension, diabetes, and atherosclerosis. The perfusion pressure can also be affected if there's a sudden rise in the intraocular pressure. So to conclude, considering that the incidence of primary angle closure with reports of ischemic optic neuropathy is quite scarce, so there could be other mechanisms involved in this particular pathogenesis. And patients who are presenting with a primary angle closure, having an RAPD, a large amount of optic nerve edema, persistent decrease in the visual acuity, and a small cup to disc ratio in the contralateral eye should raise a clinical suspicion for NAION after a primary attack of angle closure glaucoma. Thank you.
So when the eye pressure is going up, the chances of CRV or vascular occlusion is far more than affecting the optic nerve and the
Yes, sir.
circulation is from posterior. So primarily you'll end up seeing those cases more. But that in turn has an ischemic component of the optic nerve, which doesn't fall in our typical category of the NAIONs that we talk about. But
Yes, sir.
the mechanism of action is the same. So what is the kind of eye pressure beyond which, if it's rising, one should start getting worried about vascular occlusions?
30 millimeters of mercury.
So
Yeah.
if it's going beyond 30, definitely you need to treat it.
Yes, sir.
That was venous pressure.
Is also going up. Yes, sir. Thank you, sir.
Now invite Dr. Soumya Sucharita to present A Tale of Tolosa-Hunt Syndrome.
Good evening, everybody. Myself, Dr. Soumya. Today I will, sorry. Tolosa-Hunt syndrome is a rare idiopathic inflammatory granulomatous condition caused by non-specific inflammation of the cavernous sinus, orbital apex, or superior orbital fissure. Non-specific inflammation within cavernous sinus or superior orbital fissure is the cause of painful ophthalmoplegia and multiple unilateral cranial nerve deficits. Aim is to evaluate and manage a case of Tolosa-Hunt syndrome and to rule out other differential diagnoses. So coming to the case, a 23-year-old female presented with severe frontal headache with double vision for 3 weeks. Headache was sudden and onset and associated with blurry vision. Headache was followed by double vision, which was progressive and associated with drooping of the right eyelid for 1 week. So coming to the ocular examination, visual acuity in right eye was 6/9, pupil was sluggish, appearance was proptotic, and eyelid was ptotic. The MRD1 was found to be 0.5 mm and extraocular muscles were all restricted in all gauges but more in elevation and in abduction. Cornea conjunctiva were found to be within normal limit, and in left eye all the parameters were within normal limits. So coming to the 9-gaze diagnostic position of the gaze, we can see all the muscles were restricted in right eye. So coming to the differential diagnosis, they can be Tolosa-Hunt syndrome, sarcoidosis, lymphoma, GCA, meningioma, metastasis, tuberculoma. So we did some laboratory tests. So we found that RBS was 140 milligram per DL, TSH and CRP were found to be normal, ESR was raised, ANCA and AP culture was found to be negative. And on MRI, right orbital apex and adjoining cavernous sinus thickening and enhancement of extending till orbital fissure was found. So after a preliminary diagnosis of Tolosa-Hunt syndrome, the patient was started on 5-day course of high-dose intravenous methylprednisolone, that is 1 gram per day. A dramatic improvement in her extraocular motility deficit occurred. The patient was subsequently transitioned to prolonged oral steroid taper beginning from 60 milligram per day and successfully being tapered up. So the criteria according to the ICSD for Tolosa-Hunt was unilateral orbital or periorbital headache, granulomatous inflammation of the cavernous sinus demonstrated either by MRI or biopsy, paresis of one or more ipsilateral, third, fourth or sixth nerve palsy, and evidence of causation, that is headache is ipsilateral to the granulomatous inflammation, and headache was preceded the paresis of third, fourth and sixth cranial nerves. So to conclude, Tolosa-Hunt syndrome is a diagnostic of exclusion and requires advanced imaging and laboratory investigation to corroborate the diagnostic suspicion. Unilateral periorbital headache associated with third, fourth and sixth cranial nerve paresis should ideally be investigated with full workup and comprehensive brain MRI since the first attack. In case with negative brain MRI, spontaneous resolution should be considered and watchful waiting might be advisable before starting the steroid therapy. These are my references. Thank you.
What is the, why does pain occur in Tolosa? Why do you think, what is the nerve that is?
Because of the inflammation, that is why the pain occurred.
See, the third nerve, fourth
Yes.
nerve and sixth nerve are essentially motor nerve.
Yes.
So
There is fifth nerve also in cavernous sinus, so it can cause.
yeah, so usually a lot of times the first nerve actually that is going to be showing is not these nerves. It's more the
Yes.
sensory nerve. That's why the pain will always, you see. But and does the pain fully resolve, or do you think it remains even after treatment? What did your patient
Generally, mainly first the ocular motility was reserved. First, she has regained all the motility. Motility was not restricted, but the pain was little there. But it was after 1 month she has no pain.
Yeah, often the pain would tend to stay for quite some time. That therefore but as the effects is getting more and more, obviously you want to give steroids. Even high dose oral steroids can do. Doesn't necessarily have to be IV in these cases.
So did your patient have diplopia?
Yes.
So what was the course of resolution? I mean, when did the diplopia resolve? When did the headache resolve? And in case the patient had persistent diplopia or persistent symptoms, what else would you have done after steroids?
Okay, first of all, the ocular motility were reserved, but the diplopia reserved after 1 to 2 weeks of the treatment, not suddenly. Suddenly, we can see the dramatic improvement, all the gauges occur. Like she has all the gauges different, but it was eventually,
So first, the extraocular motility
Yes, yes.
improved,
Then
followed by
diplopia.
diplopia.
Headache was resolved after 1 month actually, properly, completely
So
resolved.
the last to go was the headache,
Yes.
right? So if she was not very responsive to steroids, what else could have been done after that?
Actually, if she is not responding or problem to steroid, we can give immunosuppressive agents or some
Immunomodulators. Yes.
immunomodulators.
Azathioprine works well.
Azathioprine,
Yes.
yes.
Thank you.
Thank you.
Dr. Smita here.
Good evening. My presentation is tuberculoma in pregnancy, a rare presentation. So India has nearly 21% of the global burden of tuberculosis among pregnant women, with tuberculous meningitis manifesting in 5 to 6%. Non-specific symptoms delays the diagnosis in pregnant women. Early initiation of ATT and good compliance is needed for favorable maternal and perinatal outcome, which can otherwise turn fatal. So, in this case, there was a 21-year-old primary gravida at 4th month of pregnancy who presented in March 2024. She had complained of loss of vision in the temporal aspect of both eyes for the past 1.5 months. No prior history of any major illness, trauma, or prolonged medications were present. On clinical examination, we found that in both her eyes, her vision had dropped to 624 and N12. On the color vision chart, she was able to read only one plate. Pupil showed a RAPD in the right eye. Her EM are full, free, and painless. Both anterior and posterior segment findings, including the optic disc, was noted to be normal. So we advised her a visual field test along with a color fundus photo, out of which she only underwent the visual field test that revealed a bitemporal hemianopia. So she was advised an urgent MRI brain and orbit which revealed a lobulated suprasellar mass in region of hypothalamus that appeared to arise from the optic chiasma and possible infiltration of both intracranial optic nerves and optic radiations. So an urgent neurosurgery referral was done, and patient was also counseled about the possibility of an MTP. Management, she was lost to follow-up, but presented back in July 2024 in the 7th month of pregnancy. During this intervening period, she had undergone a month of alternative therapy. She had developed headache following the alternative therapy and had presented in the ER of a multi-specialty hospital with headache, vomiting, and in a drowsy state in late April, where she was resuscitated, administered IV antibiotics. Here, she underwent a repeat contrast-enhanced MRI brain and a CSF analysis that showed a suprasellar mass, and CSF was gene export positive for tuberculosis. So her final diagnosis was suprasellar tuberculoma with tubercular meningitis in pregnancy. She was started on ATT and was under steroid cover. She was under combined pulmonology, OBG, and neurosurgery monitoring. She presented back to us in July and had worsened vision in the right eye, and both optic nerves by that time had showed pallor. Optic nerve pallor, worsening vision, and visual fields can be from both compressive neuropathy with contribution from ethambutol in ATT. So ethambutol was stopped by the treating pulmonologist to prevent any further drug-induced vision loss. MRI in August 24 showed a decrease in the size of the suprasellar mass, but involving pituitary stalk and few other enhancing small nodularities in the basal cistern. Her ophthalmological evaluation was done again in November 24, where the BCA in the right eye had improved to 624 N18 and in the left eye to 69 N6. Her color vision has also improved in both the eyes. She still had a grade 1 RAPD, and both the discs showed pallor. The right eye disc was more paler than the left eye. Her visual fields had improved since July 2024. Her child was 3 months old in November 2024, and child was also under ATT. So conclusion is, tuberculoma in pregnancy is a rare phenomenon, often because features can be masqueraded by general features of pregnancy, thus preventing diagnosis. Increased susceptibility may be because pregnancy partially suppresses cell-mediated immunity in favor of antibody response, so reactivation of a latent TB is possible. Commonest presentation is with seizures. In our case, it was a visual complaint, which is usually rare. Successful treatment of neurogenic TB is possible even in pregnancy with proper medical measures. Thank you.
This lesion that was there in the pituitary area. Were there other lesions as well that had led you to the diagnosis?
Pardon, sir?
So she didn't have any seizure or any other disorder?
No, no.
Only purely a cellar, the picture.
Initially, she had a suprasellar mass. When she had presented in the multi-specialty hospital, I couldn't access the MRI for that. She was drowsy, she had very headache and nausea, vomiting. There, they had repeated the MRI, and they found the suprasellar mass. But following MRIs showed a few nodularities in elsewhere also.
Because that can explain the systemic features, not just this. But yes, I mean, changes like this similarly, to the pituitary gland. Otherwise, also there is a, during pregnancy, apoplexy is
Yes.
also known for, because there is increased vascularity. Sometimes it will feed on the that time for these tuberculosis also.
Any electrophysiology that was done pre or post? Why was the child on ATT?
Apparently, if tuberculoma is, tuberculosis is present in pregnancy, it's often the norm to treat the child also. I just got to know that from the treating pulmonologist. They give a
So what would be the regime for the child?
normal 6 months course.
That for
Maybe it's just the close
tuberculoma.
contact. So that may work actually from a chest TB.
It's an extrapulmonary this thing. So
Yes.
in an extrapulmonary, I don't think that. But you should have referenced it since you are saying it on a platform like this. I think it would have been better if that was referenced or there was like some concrete evidence to that statement. This being an extrapulmonary one, I don't really sort of agree to it. But anyway, thank you.
Himanshu's here.
Dr. Himanshu Prakash.
Not you. Okay.
Dr. Navina Murli Krishnan. Two, yes. Yes, please go ahead.
So good evening to one and all presenter. I would like to present a case of colitis manifesting as a third nerve palsy. So a 15-year-old girl presented to us with complaints of drooping of right upper lid and pain in right eye since 3 days. She was apparently normal 1 week prior to our presentation, after which she had symptoms of vomiting associated with headache, for which she was treated as acute gastroenteritis by a local physician. There was no history of defective vision, transient obscuration of vision, or no history of fever. On examination, she was appearing weak with mild dehydration. Her vitals and systemic examination was normal. Her visual acuity in both eyes was 6 and she was able to read all plates in Ishara-stat. Her anterior segment examination showed right eye complete ptosis, which on elevating showed downward and outward displacement of the globe. Her conjunctiva, cornea, and anterior chamber and iris were normal, but the pupil was dilated and fixed in right eye. Extraocular movements of right eye showed elevation, adduction, and depression limitation. Left eye anterior segment examination was normal, but the fundus examination of both eyes showed established disc edema. With the presentation of unilateral oculomotor nerve palsy with both eye disc edema, a compressive etiology was suspected and MRI brain was advised. MRI showed a poor enhancing mass at the level of foramen of Monro, which was causing obstruction of CSF flow from the lateral ventricles to the third ventricle, causing dilated lateral ventricles seen in the coronal section and sagittal section, suggestive of colitis with obstructive hydrocephalus. In addition to it, there was lateral deviation of right lobe, which was suggestive of third nerve palsy. Along with it, there was prominent nerve sheath complex and periventricular interstitial edema was seen, which was suggestive of increased intracranial pressure. Hence, the patient was referred to neurosurgeon, where she underwent emergency endoscopic excision of the cyst, which was uneventful. On POD 15, there was partial improvement of ptosis, but she had persisting headache, for which CT brain was advised, and there was communicating hydrocephalus. Hence, she underwent shunt surgery. On 1 month follow-up, there was complete resolution of ptosis in right eye, and there was normal pupillary light reaction, and her extraocular movements were full and free, and both eye there was resolved disc edema. Hence, I'll come to a discussion where the colitis is a slow-growing benign neuroepithelial cyst, which most commonly seen at the roof of third ventricle. This accounts for 1% of all intracranial neoplasms. They are usually diagnosed in the third and fifth decade of life, mostly being an incidental finding. Occurrence in the pediatric age group is very rare, which leads to a diagnostic challenge because of its atypical and aggressive initial presentation. In a case series published in 1980 of 33 cases, all of them had bilateral papilledema, and 15 of them presented with progressive increased symptoms of increased intracranial pressure without localizing signs. Among them, one patient presented with third nerve paresis. And another case series where a patient presented with headache and double vision due to third nerve palsy as the initial case presentation. However, none of the literature had a definitive localizing cause for compression of third nerve palsy in these cases. And also, we found that transient oculomotor paralysis can occur in the event of acute rise in intracranial pressure without localizing cause. Hence, I like to conclude that third nerve palsy can also present as a non-localizing sign in following space occupying lesion with acute rise in intracranial pressure in the absence of uncal herniation or direct midbrain involvement. The involvement of third nerve palsy indicates the severity of the disease and the need for early detection and prompt treatment. Thank you.
Thank you. It was well presented. I have 3 patients with colloid cysts, and it's been several years since they are on observation. So none of them has been symptomatic. So this was really sort of enlightening to see how fast it responded. How fast it manifested, and then it responded to treatment. That was interesting.
Thank you.
Dr. Nagaruki.
Good evening all. Today's my topic is unveiling the hidden mystery behind oculomotor nerve palsy. So the introduction is cavernous sinus meningiomas are a diverse group of meningiomas occurring in and around cavernous sinus. These primarily in the cavernous sinus or involve the cavernous sinus secondarily. Patient harboring cavernous sinus tumors most frequently present with oculomotor deficits as cranial nerves 3, 4, 6 passes through the cavernous sinus. Herein we highlight the presentation of cavernous sinus tumor with isolated third nerve palsy. Here, a case of 55-year-old female presented with complaints of double vision and drooping of right upper lid for past 3 months. History of gradual drooping of right upper lid with a history of defective vision in right eye, and she is a known case of diabetic for past 2 years and no history of trauma or head injury. On her oblique examination, her both eye corrected visual acuity was 6/12, and on right eye lid shows ptosis with anterior chamber normal depth and iris color pattern normal, and pupil is 4 mm dilated, non-reacting to both direct and consensual light reflex. Lens shows immature cataract, and EOM was restricted in adduction, elevation and depression, whereas the left eye oblique was completely normal, and the pupil was reacting to both direct and consensual light reflex. Here is the picture of the patient showing the restriction of the eye movement in adduction, depression and elevation. On diplopia charting, maximum separation of crossed images in levo version, levo elevation and levo depression, that is suggestive of right third nerve palsy. What's FODA test showed crossed diplopia showing the 5 images, and both eye fundus shows disc and vessels normal, and both eye macula appears to be normal with foveal reflex plus. Another cranial nerve examination was normal, and the impression was right eye pupil involving isolated third nerve palsy. On further MRI imaging, there was a well-defined circumscribed extraaxial mass centered on the right cavernous sinus, extending to orbital apex with a bone hyperastosis. It was a feature suggestive of right cavernous sinus meningioma, and patient was admitted in neurosurgery department for the excision of the tumor. Here is a picture showing a tumor in the cavernous sinus, which was suggestive of cavernous sinus meningioma. Now moving on to the discussion, cavernous sinus meningioma is the most common primary cavernous sinus lesions. These are technically difficult to resect because they tend to invade vital neurovascular structures within the cavernous sinus. These are the benign tumors that involve the cranial nerves, and in general, pupil involving isolated third nerve palsy prompt an ophthalmologist to suspect compressive lesions at basilar level. But rare presentations like a cavernous sinus meningiomas should be considered as differential diagnosis. Thank you.
Did the patient undergo any surgery?
Yeah, ma'am, suggested, but because of a neurosurgical risk, patient denied surgery, ma'am.
Okay.
Is there a radiation therapy or EBRT or something else can be then offered in that case?
Yeah, we discussed with the neurosurgeon, sir, but they said even after that, patient, because of the vital structures, there will be further complications and there will be increased ICT, and they have explained everything, sir, so patient denied for it.
So refuse consent.
Yeah.
Okay. So what do we learn from this case then, basically?
Yeah, mostly because of cavernous sinus lesions, it may involve all the nerves. So mostly it was present first with because of the inside of the cavernous sinus, the sixth nerve is the most commonly affected because it is in the substance. But here is the presentation with the isolated third nerve palsy, which may lead to the further imaging, and then we came to know that it was a cavernous sinus meningioma. So on further, if the patient didn't come for follow-up, so on further follow-up, we may have some idea whether it's involving other nerves.
Imaging was done because you're suspecting an aneurysm or something else at that time.
Yes,
primarily isolated
yes,
third nerves.
yes, sir.
The location is the same again.
Yeah, yes, sir.
Again would be in that.
Yes, sir. So we have to have a DD of this also. Yeah. Thank you.
Thank you.
Speakers can come for a photograph after this up front.
Just finally calling out the absentees to make sure that they have not come. Dr. Nancy Sharma and Dr. Himanshu Prakash.
Not there?
Not there?
All right.
So just give us a minute and then the speakers can come in front and let's have a picture together.